So now let us see what is the clinical use of our local anesthetic. See, this whole group of drug, it is deposited locally, and depending where you are depositing it, the regional anesthesia of different types comes into different type of regional anesthesia has been defined. So depending upon place of deposition, we can define regional anesthesia in various types. And the first one is topical anesthesia. What do I mean by topical anesthesia? In topical anesthesia, what we do, we deposit the local anesthetic on skin surface or on the mucous membrane. So deposition of the local anesthetic on mucous membrane of tracheobronchial tree or on esophagus, right, for let's say endoscopy and all, or on the skin surface, a special preparation comes. This is called topical anesthesia. So deposition of local anesthetic on skin surface, right, or on mucous membrane to produces topical anesthesia. So topical anesthesia very commonly used for cataract surgery, where the eye drops is used topically to produce a anesthesia of the cornea, right? It is very commonly used in endoscopy and all. Spray is used or a gel is used to produce a topical anesthesia, and a very popular preparation for the skin comes, and for skin topical anesthesia. Skin is a keratinized layer, and penetration of the drug through skin is very tough. But one combination comes, which I specially want to mention, is EMLA, something called EMLA cream, which is a special preparation for skin topical anesthesia. This is not used on mucous membrane. So skin topical anesthesia, right? EMLA is mixture of two local anesthetic. EMLA stands for eutetic mixture of local anesthetic, and it has lignocaine and it has prilocaine present in it. Okay, it has lignocaine and prilocaine present in it in 2.5% concentration each, right? What we do, we put the EMLA cream on the skin surface, attach an occlusive dressing, leave it for a contact period of minimum 45 to 60 minutes, that's for nearly 1 hour, and then it will, this cream, this is eutetic mixture. Eutetic means easily melted. Now melting point of the mixture of ligno and prilo is much less than the melting point of the individual drug present in the EMLA cream, that is ligno individually or prilo individually. Melting point of the combination is less. So it melts and penetrates the skin surface and produces a surface anesthesia of 2 to 4 millimeter depth. So it produces a surface anesthesia of 2 to 4 millimeter depth. But you know, it depends upon the duration for how long you have put EMLA cream. There are a variety of procedures which can be done under EMLA cream. We can put a cannula under EMLA cream, and for cannulation we need hardly a contact period of 45 minutes to let's say 1 hour, not more than that. But if I have to take a skin graft, we need a more depth. So 2 hours application of EMLA cream, then only a split skin graft can be taken. It can be used for circumcision, it can be used for lithotripsy, so it can be used for port wine stain removal, superficial procedures, right? Any superficial procedures can be done under EMLA cream, and depending upon the depth, the duration of the cream should be applied on it, right? Now, one important thing, EMLA is prepared specially for the skin topical anesthesia. How do you apply it? Wherever we have to apply it, we clean that area, then visually inspect it for any abrasion or any discontinuity of the skin. If this is so, I would not put amla because it will get systemically absorbed if there is any abrasion or discontinuity of the skin. And since it has a very high concentration of ligno and prilo, risk of systemic toxicity would be more. So remember, we have to apply it on skin and intact skin. Any abrasion, we cannot apply it. This preparation is for topical anesthesia only for skin, not for mucous membrane. Okay, and this preparation is used in adults, in infants, but we avoid it to be used in neonates. Neonates, they cannot metabolize such a high dose of ligno and prilo. We don't use it in neonates. So 3 contraindication I said. It is contraindicated for mucous membrane. It is contraindicated in neonates. It is contraindicated for any breach in skin. Okay. And what are the procedures it is used for? Venous cannulation, the most popular. Split skin grafting, circumcision, lithotripsy and all. Then port wine stain removal, any superficial procedure. Okay. So one important thing, amla cream in topical anesthesia. Okay. Okay. Now local infiltration. Local infiltration, what is done? Near the, let's say, smaller nerve endings, right? Just in the dermis, we deposit the local anesthetic near the smaller nerve endings. So, deposition of local anesthetic, right, in dermis near smaller nerve endings is local infiltration. Now, this is very commonly used by dental surgeons and all. So, let's say if I have to get a tooth extraction done, this is the teeth, okay. Now, this teeth is, right, it is innervated by these nerve fibers and I have to get it removed. So, what we do, we give local anesthetic by infiltration method near these terminal nerve endings and this area gets anesthetized, right, and we can remove the teeth. So, this is what is called local infiltration. Now, for local infiltration, mostly adrenaline is added, right. So, for local infiltration with local anesthetic, we always add adrenaline in 1 in 2 lakh to 1 in 4 lakh concentration, right. So, 1 in 2 lakh to 1 in 4 lakh concentration, we add local anesthetic with adrenaline. Got my point? So, this is for local infiltration. Then peripheral nerve blocks. Here, local anesthetic is deposited around the tissues near major nerve trunks like brachial plexus or sciatic or femoral, and a wider area gets anesthetized. So, deposition of local anesthetic around the tissue of major nerve trunks. This is called peripheral nerve block, right? Example, brachial plexus, sciatic, etc. Here also, very commonly, additive is added. We talked about so many additives. We talked about your dexamethasone, right? We talked about your adrenaline, right? So, these are added with peripheral nerve blocks to increase the duration. In detail, we'll talk about peripheral nerve block in our topic, peripheral nerve block. Okay. Then we have TIVA, a special type of regional anesthesia. What does this TIVA stands for? TIVA stands for total intravenous anesthesia. Total intravenous anesthesia. Now, this is a very contradictory thing. I'm saying intravenous. Until now, I told you that local anesthetic is given locally, never intravenously, right? So, what is this TIVA, or we call it Bayer's block, because this was developed by Dr. August Bayer, right? Now, this is also a type of regional anesthesia, but In this, the local anesthetic is not deposited locally but given systemically. Now, TIVA is practiced in upper or lower extremities. Okay. In TIVA, what we do, let's say for this limb, I have to provide TIVA. What do I use? I put a tourniquet and I inflate the tourniquet, double the blood pressure of the patient, and take this limb, separate this limb from the systemic circulation. So I have put the tourniquet, a proximal, dual tourniquet, just to increase the safety. And I cut this limb from rest of the circulation. Then an IV line is put, IV cannula is put, another IV cannula is put in the other limb for managing any complication. But local anesthetic is given through the IV cannula in the tourniqueted limb. The local anesthetic goes through the blood in this, remains in this limb only, will not go in the systemic circulation, and all the nerve fiber of this area will get anesthetized. Okay. Any procedures like small procedures like your tendon removal, or let's say small surgeries of upper limb or lower limb can be done under TIVA. Okay. So TIVA, or total intravenous regional anesthesia or bias block, right? In this, tourniquet separates limb, right? And drug is given intravenously in the limb. Okay. And tourniquet is not opened till the stipulated time period. The most important thing which you have to remember is the drug which we use, the local anesthetic which we use. We mostly use lignocaine or we use prilocaine. Ligno or prilocaine. Most commonly we use lignocaine. Most common is lignocaine because of the better safety profile of lignocaine. How the safety profile is decided, in a moment we will discuss. So lignocaine is the most common one which we are using. Prilocaine less commonly, but prilo is also safe, right? So ligno or prilo. But drug contraindicated for TIVA. The local anesthetic contraindicated for TIVA. Very important. Bupivacaine, ropivacaine, and your levobupivacaine, all the congeners of bupivacaine. Now, bupivacaine is this group, bupivacaine, your ropivacaine or levobupivacaine. They are very cardiotoxic local anesthetic. So, they are not used for TIVA. If little systemic absorption also happens by a loose tourniquet or any problem, the risk of systemic toxicity is very high. So, remember this, we are not using the Bupiva, Ropiva or Levobupiva for TIVA. Now, TIVA itself is contraindicated. TIVA is contraindicated in case of any patient with sickle cell disease. Sickle cell disease, because tourniquet if we will tie, it will precipitate sickling. Then peripheral vascular disease. So, in these conditions, we are not putting the tourniquet. Any condition we cannot put the tourniquet, TIVA cannot be given. Okay, just remember this, TIVA. And one more thing, for TIVA, the concentration of lignocaine which is used, I'll give you a tabular form also, is 0.5%. We are using 0.5%, right? Which is a very lesser concentration of lignocaine. Okay, so this is about TIVA, one of the way of regional anesthesia. Then neuraxial blockade. Now, this is your spinal cord, and from spinal cord, the spinal nerves come, right? So, when you block the spinal nerve, either by spinal anesthesia or by epidural, we call it neuraxial blockade. So, neuraxial blockade we have to discuss spinal anesthesia and epidural anesthesia. So, we will discuss it in the topic central neuraxial blockade. Right. So, when local anesthetic is put in subarachnoid space, we call it spinal. We put in extradural, we call it epidural. Got it? So, this is neuraxial blockade. So, another type of regional anesthesia where we put local anesthetic. Okay. So, these are the different types of regional anesthesia, and according to the place of deposition of local anesthetic, it has been divided. Okay. So, now let's see what are the concentration of the local anesthetic we use for these different regional anesthesia. The most common one I have discussed with you. Bupivacaine and its congener levobupivacaine. This can be used for local infiltration. Bupivacaine is not used for topical. Not used for topical. Remember, topical penetration is not there. Infiltration, very commonly it is used. And we use mostly 0.25% for skin infiltration, for wound infiltration, 0.25%. Right? Onset is moderate, of moderate onset, and duration 2 to 8 hours. We get analgesia for 2 to 8 hours. We use Bipiva and Levobupiva for peripheral nerve block, right? Very commonly for peripheral nerve block. Concentration 0.25 to 0.5% depending upon the nerve fibers we want to block. If only analgesia, we use a lesser concentration. If along with sensory fibers we want to block motor fibers, we use a higher concentration. So for peripheral nerve block, again onset moderate to slow, 4 to 12 hours according to the additives if we have used with this bupivacaine. We can increase the duration from 4 hours till 12 hours. Okay. We can use it for epidural from 0.5 to 0.75%, 2 to 5 hours duration, and we can use it for spinal 0.5 to 0.75%, 1 to 4 hours for duration. Very commonly we are using bupivacaine. It's the most common drug we are using for the spinal anesthesia and for epidural anesthesia. The concentration 0.5 to 0.75%. Okay. So this is about bupivacaine. Lidocaine, the next common one. Now lidocaine, we use it for topical, very commonly 4% concentration. We use it for infiltration, 0.5 to 1% concentration. If you have seen a lidocaine vial, it comes in 2% concentration. So equal amount diluted with normal saline, it becomes 1% concentration, and we use it for local infiltration. Now for IVRA, we talked just now about IVRA, intravenous regional anesthesia, and for this we use the concentration 0.25 to 0.5%, a very low concentration. For peripheral nerve block, for lidocaine 1 to 1.5% concentration, for epidural 1.5 to 2%, and for spinal 1.5 to 5% concentration is used. So basically lidocaine is used for all the different type of regional anesthesia, and the lidocaine onset is pretty fast, duration is moderate, it is intermediate duration. So duration is intermediate or moderate. Bupiva has a longer duration. Now remember, lidocaine is the only local anesthetic which can be given intravenously, IV also. IV, what is the role of IV lidocaine? Lidocaine's 3 important IV role has been seen as analgesic, intravenous analgesic also, and as antiarrhythmic. It is used in treatment of ventricular arrhythmias, and as anti-epileptic. So these are the 3 important IV use of lidocaine. Okay. Then ropivacaine, another congener of bupivacaine. Now it is also used for infiltration, peripheral nerve block, epidural anesthesia, and epidural analgesia in following concentration. For infiltration 0.2 to 0.5%, and for peripheral nerve block 0.5 to 1%, epidural 0.5 to 1%, and for analgesia we further decrease the concentration. Onset like Bupiva and Levo, moderate to slow, and duration is long acting. Okay, these are the commonest drug. Okay, apart from this, we also have to use local anesthetic for topical, and only Lido in this group is used for topical. Bupivacaine or any of its congener is not used for topical, but the combination which we use for topical, right? Cocaine, benzocaine, the ester, and ligno and prilocaine combination I talked about. This is very commonly used for topical, and Lido and Prilo for skin topical also in the form of Amla cream. Okay. Now, onset of Lido and Prilo is, the Amla is slow. We need a contact period of minimum 1 hour, and we get a analgesia for 3 to 5 hours. Benzo and cocaine, we have a fast onset but slow duration of action, small duration of action. Procaine is used for spinal anesthesia, was used for, nowadays not used, not much use. Tetracaine, again ester, can be used for topical and for spinal anesthesia. Not used nowadays for spinal, mostly it is used for topical. So ester group, mostly used for topical. In ester, there is only one local anesthetic, again whose let's say use has been restarted recently few years back is something called, which I haven't written here, I wanted to write it separately, chloroprocaine. Chloroprocaine. The chloroprocaine, what were the things we knew about chloroprocaine in the list which we discussed when we classified the local anesthetic long back in starting of this topic? I told you that chloroprocaine, right, is short acting Eastern local anesthetic, isn't it? Chloroprocaine is short acting Eastern local anesthetic. Now, initially when it was introduced with a preservative which was neurotoxic. So when it was used for spinal, some toxicity was seen to the nerve, direct toxicity, and its use was removed. Now again it has been introduced with a special preservative which is not toxic to the nerve, and again the use has been restarted, especially for spinal anesthesia. Why it is so good? Because of its shortest duration. So 1%, 2% chloroprocaine we are using very commonly nowadays for spinal anesthesia when we want to have a very short duration, So chloroprocaine for spinal anesthesia. We're using it very commonly for spinal anesthesia in 1 to 2% concentration. Onset is fast and duration is less. So smaller duration, right? Smaller duration. Okay, this is chloroprocaine. Understood? So this is about the drug. So these drugs are used for following regional anesthesia, but we have to be very careful while giving these drugs. So let us talk about the complication of local anesthetic. Complication. Let us talk about toxicity of local anesthetic, the most important complication, something called LAST, local anesthetic systemic toxicity. Local anesthetic systemic toxicity, right? What is this local anesthetic systemic toxicity, right? See guys, if the drug will get systemically absorbed, whatever drug you give, only 2 to 3% penetrates the nerve fiber. Rest remains there and gets systemically absorbed. Gradually gets distributed to the organ and gradually gets eliminated. So when it is coming in the blood, whatever we are giving, only a small fraction is doing the work. Rest is going in the blood. So there is always a risk of systemic toxicity. And that is why the maximum safest limit should not be exceeded. And two system toxicity is very high: central nervous system and cardiovascular system. Let us talk about toxicity which it gives to central nervous system. So central nervous system toxicity is dose dependent. As the blood concentration of local anesthetic increases, the symptoms comes. So CNS toxicity features are dose dependent, right? It is dose dependent. Okay, if your dose in the blood is 1 to 5 microgram per deciliter, we get analgesia. This is the safe limit. But as the dose increases from, let's say, to 5 to 10 microgram per deciliter, we get lightheadedness, tinnitus, circumaural numbness, right? Comes to the patient. Patient starts complaining, becomes apprehensive, becomes lightheaded, starts complaining of tinnitus. If further the concentration increases to 10 to 15 microgram per deciliter, seizure and unconsciousness. If further increases, it can progress to coma and respiratory arrest and further cardiovascular depression. So, CNS symptoms: patient becomes apprehensive, patient becomes lightheaded, right? Then tinnitus, right? Perioral numbness, perioral twitches, all these comes. Then seizure, then coma right? So as the dose is increasing serum concentration is increasing, the symptom is coming. Okay. These are the features of CNS toxicity, right? Above 25 would be the cardiovascular depression, which I will discuss with you. Okay. So these are the clinical features of CNS toxicity. Now, there are few factors which can increase the CNS toxicity. At the same serum concentration, if patient has few factors, the risk of CNS toxicity would increase. So what are the factors which can increase the risk of CNS toxicity? Decrease in protein binding. I talked about protein binding. Bupivacaine is highly protein binded. In case of patient with hypoproteinemia, hypoalbuminemia, right, there would be decrease in protein binding, more free drug would be available. Decrease in clearance, like in hepatic dysfunction, like in pregnancy, like in let's say patient with liver dysfunction, cardiac dysfunction. Decrease clearance, the risk of toxicity would increase, right? Acidosis, the risk of toxicity would increase. Hypercarbia, if interrupt hypercarbia, risk of toxicity, CNS toxicity would increase. So all this would increase risk of CNS toxicity. So we have to be carefully see that patient should not have any associated conditions like this, hypercarbia or acidosis, right? Because risk of systemic toxicity will increase. Now let us see what are the CVS factor. Now, clinical features of cardiovascular toxicity. Cardiovascular toxicity. Now, first thing which happens, first effect on cardiovascular system is mostly hypotension because of the vasodilatation which it causes. So, first thing is hypotension, right? Because of vasodilatation. Then what happens? Because of hypotension, the blood pressure, of course, hypotension is decreased blood pressure. Blood pressure is less. But because of CNS depression, the reflex sympathetic tachycardia and all does not happen. So, no baroreceptor reflex because of CNS depression, right? So, uncoupling of CNS and CVS happens. So, no baroreceptor reflex, more decrease in cardiac output. Then what happens? They block the sodium channel. What did local anesthetic do? They block the sodium channel and they slow the conduction of the heart. So when the conduction of the heart will get slowed, what will happen? Your PR interval will get prolonged, QRS will get prolonged, everything will get prolonged. And what can happen? Arrhythmias can happen, which can ultimately lead to cardiac arrest. So, conduction of heart slows down, right? This can lead to arrhythmias and this can lead to cardiac arrest. Okay. So this is what can happen in cardiovascular toxicity. CNS toxicity, these clinical features, CNS toxicity, they can be managed. But CVS toxicity, right, this can be life-threatening. This can be very much life-threatening. Okay, these can to some extent be managed, but this can be life-threatening. And you can see at a higher serum level, the cardiovascular depression will happen, right? So cardiovascular toxicity happens at a higher serum concentration. CNS toxicity happens at a lower serum concentration. So for every drug, there is something called CC-CNS ratio is calculated. What is CC-CNS ratio? CC-CNS ratio is dose at which cardiovascular toxicity and dose at which CNS toxicity. Dose at which CNS toxicity. Okay. Now, if this ratio is high, right, then that's a better thing, better drug. Because CNS toxicity is less life-threatening compared to CVS toxicity. If you see bupivacaine, I told you We never use bupivacaine for IVRA because it is most cardiotoxic. Okay. Now, bupivacaine, its relative potency for CNS toxicity is 4, which is high, and CVS to CNS ratio, that is CC-CNS ratio, is 2, right? So, which is a low CC-CNS ratio. Difference between CNS and CVS toxicity serum concentration is less. Levobupivacaine, CVS CC-CNS ratio is same, but relative potency to CNS toxicity is less compared to bupivacaine. Levobupivacaine is S isomer of bupivacaine and it is less toxic. Levobupivacaine is less toxic than your bupivacaine. Okay. Lidocaine. We are comparing the CNS toxicity with keeping lidocaine as 1. Compared to lidocaine, how much these drug has more CNS toxicity. Bupiva has 4 times, levobupiva has 2.9 times. Okay. CC-CNS ratio of lidocaine is 7, which is safe, pretty safe. Procaine, it is less CNS toxic compared to lidocaine. So, 2 drugs I mentioned for IVRA, Lido and Procaine. Lido and Procaine. Why? Because it is safer. Relative CNS toxicity is less. CC-CNS ratio is 3.7. Ropivacaine, again a congener of bupivacaine. The CNS toxicity 2.9 and CC-CNS ratio is 2. Just remember, lidocaine has highest CC-CNS ratio, so considered safest, and it is the only local anesthetic which can be given intravenously as antiarrhythmic, analgesic, antiepileptic. Bupiva is most cardiotoxic, low CC-CNS ratio and relatively high CNS toxicity potency. It has 2 congener, levobupivacaine and ropivacaine. Both are less toxic congener of bupivacaine, right? Remember this, okay? Okay. Now, if the last happens, what would be the treatment? Treatment of last. Treatment of last is mostly symptomatic. Whatever symptom is coming, you are managing the symptom. So, treatment is mostly symptomatic, is mostly symptomatic. Okay. If patient starts having seizure, we give anti-seizure medications, like we give our patient midazolam as the choice. Best drug we give midazolam. Remember, we give midazolam. Midazolam, let's say, stops the seizure also and it increases the threshold of seizure also. So, midazolam would be the best drug in this situation. We should not use propofol or any other hypnotics because it will cause more CNS depression. So, if we want to treat the seizure, we should avoid hypnotics like propofol to stop the seizure. So, we should not use what they will do? They can do more CNS depression and they can cause CNS depression, they can cause hypotension, more hypotension. So, this should not be used. Though propofol is a very good drug to stop seizure, but here we should avoid it. Okay, so midazolam would be perfect, or long-acting benzodiazepine would be perfect. We can use lorazepam, we can use diazepam, but midazolam propofol should be avoided. Okay, now if patient starts having arrhythmia and all, right? So, best drug for treating arrhythmia in this case is amiodarone, right? Amiodarone and antiarrhythmic, because most common arrhythmia is ventricular, which is happening with local anesthetic systemic toxicity. One other local antiarrhythmic which can be used is lidocaine for ventricular arrhythmia, but here lidocaine has to be avoided, right? So, should not use lidocaine because it can further increase the toxicity. It's also a local anesthetic which binds to the sodium channel. So, lidocaine, should not use lidocaine as an antiarrhythmic, though lidocaine is an antiarrhythmic, and should not use beta blocker, right? Should not use calcium channel. So, should not use beta blocker or calcium channel blocker, right? we should avoid these drugs also, because they will further, let's say, decrease the automaticity of the heart and can cause problem. Adrenaline would be one of the best drug for increasing the blood pressure in this situation. So, for hypotension, we should use adrenaline or ephedrine to increase the blood pressure. If patient goes into cardiac arrest, definitely we have to do CPR, cardiopulmonary resuscitation, right? Now, whenever we suspect the last local anesthetic systemic toxicity, one antidote is 20% intralipid emulsion. 20% intralipid emulsion. Now, this intralipid emulsion, what does it do? Your local anesthetic undergoes a lipid escape. When we give it intravenously, it binds to any LA which is remaining in the blood, does not let it go to the CNS and CVS, and it also pulls the local anesthetic from CNS and CVS, right? Lipid escape of local anesthetic happens. So, this is a very good drug, right? So, it does two things. Number one, it binds to local anesthetic and prevents its further attachment to the sodium channel and prevents further attachment to sodium channel, and it also causes lipid escape of LA from the sodium channel. Plus, it can also increase the blood pressure. It also increases the blood pressure, right? So, it helps in many ways. What is the dose? What is the dose of local anesthetic which we use for, what is the dose of 20% intralipid which we use for last? We start with 1.5 ml per kg bolus, we give the bolus dose, followed by 0.25 ml per kg per minute infusion, okay? If patient is not improving, we can increase to 0.5 ml per kg per minute infusion. So, we can increase, we can go on increasing. Maximum which we can give, maximum is 10 ml per kg body weight in 30 minutes. This is the recommendation. So, whenever last happens, we suspect last, we call for help, right? Then we start the symptomatic management. Midazolam, never use sedative hypnotics. Antiarrhythmic, we use, what do we use? Amiodarone is the best. Never use lidocaine or calcium channel blocker. We start adrenaline infusion, we can start to increase the blood pressure, or ephedrine we can give. And if cardiac arrest happens, CPR, and as soon as possible, we start 20% intralipid emulsion. Now, this should always be in the OTs where you are giving the regional blocks, 20% intralipid. Let's say you should always have a crash cart there with 20% intralipid emulsion and all the drugs required to manage last, because last can be life-threatening. Got it? What are the other complications which can happen? Now, before I tell you the other complication, one more thing I want to talk about before I talk about the neural toxicity of local anesthetic. I talked about the cardiotoxicity of local anesthetic. Okay. Now, bupivacaine, repeatedly I am saying bupivacaine is most cardiotoxic, right? It is most cardiotoxic. Why? What is the reason that it is most cardiotoxic? The reason, compared to other local anesthetic, it binds to the sodium channel in resting and inactivated state more avidly. So, it binds more strongly to cardiac sodium channel in resting and inactivated state. Keep it in that state for prolonged period. And most of the drug, they bind to the sodium channel of heart during systole and they dissociate during diastole. Bupivacaine does not dissociate during diastole, and more bupivacaine starts getting accumulated in the sodium channel of the heart. So does not get dissociated easily. Does not get dissociated easily, right? So because of this, it is most cardiotoxic. But it's a good drug, long acting, good for differential blockade. So there are, bupivacaine is a racemic mixture. It's a racemic mixture, and it has S and R isomer present in it. S and R isomer in equal amount. What was seen that R isomer was binding to the sodium channel of heart more avidly. S isomer was comparatively less notorious. So an action of S isomer was also there, but it was less avidly binding to the sodium channel of heart. So pure S isomer of bupivacaine was made. So two drug, pure S isomer. One is your levobupivacaine and other is ropivacaine. In ropivacaine, there was one more good thing done. The butyryl channel was replaced by propyl channel. So again, it became less avidly binding to the sodium channel of heart. So these two are congeners of bupivacaine, but the safer one. They are the safer one. So bupivacaine was most cardiotoxic, then levobupivacaine, and then ropivacaine. These are the safer bupivacaines. Nowadays we are preferring safer bupivacaine. Okay, and doses I have already told you. Okay. So we have already discussed the doses. Now neural toxicity, direct toxicity to the nerve. This can happen if you deposit the local anesthetic very much near the endoneurium or perineurium. And there was some drugs which was particularly causing neural toxicity. Chloroprocaine, previously it was said that it is causing more neural toxicity compared to other drug, but that was because of the additive present in chloroprocaine. Now the preparation which has been introduced is considered safe. So direct toxicity to the nerve, right? This depends upon two things: concentration, if you give a very high concentration, and duration of the exposure. So both if high, risk of neural toxicity is more. Today with ultrasound and all, we put very carefully drug around. We try not to put the drug near the perineural sheath, but there are practices of putting the drug near perineural sheaths also, but there is always a risk of neural toxicity. So the next complication after transient neurological symptoms I would discuss is methemoglobinemia. Now what is methemoglobinemia? There are some compounds which can oxidize the iron of hemoglobin from ferrous to ferric state. So there are two local anesthetic, prilocaine and lignocaine, right? Benzocaine, not lignocaine. Prilocaine and benzocaine. Lignocaine very rarely has shown this kind of side effect. Prilocaine and benzocaine, and one combination, Emla, that is Emla cream, which has prilocaine and lignocaine in it, right? Because of presence of prilocaine, Emla can also cause methemoglobinemia. So these three, prilo, benzo and Emla, these can oxidize iron, right, from ferrous to ferric in hemoglobin, iron of hemoglobin from ferrous to ferric. And now this, when it gets oxidized to ferric, it becomes methemoglobin. Okay, and this methemoglobin has very low capacity to bind to the oxygen. So oxygen carrying capacity of the blood is reduced. When it increases in the blood in a huge amount, we call it methemoglobinemia. Methemoglobinemia. What is the treatment of it? The drug of choice. The drug of choice is methylene blue. Methylene blue, a very important reducing drug agent. So IV methylene blue in a very high dose is used to reduce the ferrous to back to ferric back to ferrous state. So this is methemoglobinemia, which is a complication of two local anesthetic, prilo and benzocaine, mainly ligno. Few incidents has been seen, but not totally implicated to cause methemoglobinemia. Right? Now, last complication, allergic reaction. Allergic reaction can happen more with ester local anesthetic because of the byproduct para-amino-benzoic acid. So, allergic reaction more seen with ester local anesthetic. Right? Ester local anesthetic because of para-amino-benzoic acid produced by it, PABA produced by it. So this can cause more ester local anesthetic can cause more allergic reaction. Amide very less. So this is all about the complication of local anesthetic. So we discussed local anesthetic in detail. We discussed that local anesthetic is divided into two groups, ester and amide. First local anesthetic which was used was cocaine, right? Cocaine, a natural LA. Most of the ester local anesthetic are used for topical application except chloroprocaine, which is the shortest acting local anesthetic. Duration of action is shortest, and for short duration and for daycare regional anesthesia, we are very well preferring chloroprocaine for spinal anesthesia also, right? But amide group is more common. And in amide, lignocaine is the only local anesthetic which can be given intravenously, and it is one of the commonest used local anesthetic and it is used for basically for all kind of regional anesthesia which we can produce, right from topical to nerve block to epidural to spinal, etc. But overall, for postoperative analgesia and for long duration analgesia, we are preferring bupivacaine and its congener ropivacaine and levobupivacaine. Bupivacaine is a racemic mixture. So this and the dextroisomer of bupivacaine binds with the sodium channel of heart more avidly. So a safer version of bupivacaine is the levobupivacaine and ropivacaine, which are less cardiotoxic than main bupivacaine. So today we are preferring these lesser cardiotoxic version of bupivacaine for producing postoperative analgesia. They are safer and the duration of action is similar to the bupivacaine. So this is all about local anesthetic. Thank you.